Hey guys, hope you all are doing well today. Today we'll be discussing nephrology part one, and I hope to give you all the helpful and useful information, the high yield topics for especially the ones that tie into pathology and pathophysiology. So let's get right to it. One second. Right. Yeah. So if we look at the index here, these are the topics we'll be covering today. We have the functional morphology of the nephron, the glomerular filtration, its regulation, the juxtaglomerular apparatus, the tubular processes of reabsorption, secretion, urine formation, examination of renal function, which is really important in a clinical setting, and water reabsorption. And there's this, I would say, rather interesting, slightly difficult topic called the countercurrent multiplier. And yeah, hope to make that all just in slightly simpler terms for you guys. I'm sure you'll find more details in textbooks like Guyton and Costanzo, but I just hope to cover all the high yield topics and yeah, ones that tie in more with pathology and pathophysiology, right? So let's start off with the functional morphology of the nephron. So this is, there we go. And if we talk about the two key components of the kidney, uh, of the nephron in the kidney, we would have the kidney tubules and its capillaries. But before we get into that, let's just go over a bit of anatomy. We can see the sagittal and the longitudinal section over here, and as well as the coronal section over here. And you can see the medulla of the kidneys. It's pretty much this area over here is the medulla. This area is the cortex, as we know, and outside that would be the capsule, and these are the papillae. And basically, the direction in which the papillae point is the direction to which they drain. And you can see the papilla here, and then that drains into the minor calyx, which drain into the major calyx, and then into the into the pelvis and into the ureter to the bladder. And then I'd like to go over the blood supply. Um, we can see here it starts off with the renal arteries, and then that branches and goes into the segmental arteries, then the interlobar arteries, and then the arcuate artery, because they kind of form an arch over here, and that becomes the interlobular artery, which then becomes the afferent arteriole, so from artery to arteriole, and then that becomes the glomerulus, which is a knot of capillaries, and then that once again becomes the efferent arteriole. So you'd like to think of afferent as arrival, so that arrives into the nephron. Efferent exits, just some mnemonics over there, and then you have the peritubular capillaries that are around all the tubules, and yeah, and then from the peritubular capillaries you get the veins, which are just named in reverse from the arteries, right? And once you move on to an individual nephron, you can see here the glomerulus. We'll start off with that, and we'll move on to the tubules as we progress. The glomerulus is a knot of capillaries, and these are fenestrated capillaries, meaning they have pores with the diaphragms in them, so that majority of the blood can get filtered through while still preventing any cells from passing through. Because we know that capillaries are, they follow after arterioles, and that's where nutrients and gases are exchanged. However, you have different types of capillaries in different parts of the body. Here you have fenestrated ones, and these are the ones with the biggest pores because blood needs to get filtered and reabsorbed, and urine needs to be formed. So these are fenestrated and they have pores, but they don't allow any blood cells to pass through because you don't want any of that in the urine. That would be pathological. It would indicate damage to the capillary membrane and the nephron. And yeah, we'll go into the details into the next slide, but you can see the different types of cells that are available here. And this would be like capillaries, and this is the start of the nephron with the glomerular space in the Bowman's capsule. That's what it's called. You can see the podocytes over here. You can see the histological picture over here. And yeah, this is the most important part of the glomerulus. It's the glomerular filtration barrier, and it consists of these three main parts, which you definitely want to make sure you remember. That's the fenestrated capillary endothelium. And so it's fenestrated, that's a capillary, and we know that all the blood vessels are lined with endothelium. So you can see here the endothelial cell pore, you have the electron micrograph, and you have just an illustration over here, another couple of illustrations over here. You have the basement membrane with type 4 collagen chains and heparin sulfate. It's important to remember these simply because they all hold very important filtration properties that we'll come to in the next slide. And you have the visceral epithelial layer consisting of the podocyte foot processes. So you have, if you move back over here, you have the endothelium, you have the basement membrane, because endothelium is also a type of epithelium, and yeah, the podocytes are also kind of a type of it, so they have a basement membrane. And then you have the podocytes. So you have endothelium, so, and then the basement membrane, and then the podocyte. So yeah, the visceral epithelial layer consisting of the podocyte foot processes. You want to really make sure you remember these three. And then we'll go into why they're individually important. So the specific functions of the glomerular filtration barrier, you can see, is there's a charge barrier and there's a size barrier. So these are two important um, say qualities of the glomerular filtration barrier, because the blood needs to be filtered, but and even though a majority of it is reabsorbed or secreted, which we'll come to later, it can't. There needs to be some cutoff. So the charge barrier is actually really important, because that prevents albumin from entering the, the urine, because it's quite a large molecule. And even though we can see the size barrier does prevent it, but the fact that the glomerular filtration barrier contains negatively charged glycoproteins, it strongly repels the albumin and allows it to stay in the blood. And we'll come to it in a bit, but it also contributes to the oncotic pressure, and that's really important as well when we talk about filtration in the glomerulus. And then we come to the size barrier, and you have these three main parts that contribute to the size barrier. That's the fenestrated capillary endothelium, and this is the cutoff. If anything is greater than 100 nanometers, it won't allow it to pass through. That definitely includes blood cells, because say a red blood cell is around 7.5 micrometers as its diameter. It's definitely too large to pass through, because if at any point you see a red blood cell in urine, it means hematuria, and that means that the glomerulus has been damaged, the filtration barrier has been damaged, and that means there's nephron damage, some inflammation, and yeah, that'll be covered in the pathology lecture. But yeah, so you also have the podocyte foot processes that interpose, as you can see over here. The foot processes that are present here, they also prevent, in terms of size, any of the slit diaphragm of the endothelium, the filtration slits over here. These are the slit diaphragms that also prevent and filter molecules according to size. And now, if we move on to the glomerular filtration, we have two main pressures that we are talking about over here. We have the hydrostatic pressure and we have the oncotic pressure. Now, the hydrostatic pressure is directly proportional to the blood pressure. So if the blood pressure increases, so does the hydrostatic pressure, and vice versa. And the oncotic pressure depends on the solute concentrations, especially that of proteins, especially albumin. It's quite a large contributor in this. And if we think of hydrostatic pressure as kind of positive force, oncotic pressure is negative. So if you can see with the arrows over here, you would see that blood enters via the afferent arteriole, and you have here the hydrostatic pressure of the, I believe this is the glomerular capsule, but anyways, let's just say it's of the blood of the plasma, and that is going in this direction towards the tubules. And you can see over here, GC, this is pi that indicates the oncotic pressure. It's in the opposite direction because if there's protein anywhere, it draws water to it. It attracts water. It's its natural property, and that's what oncotic pressure is is about. And yeah, blood enters via the afferent arteriole because of the immense hydrostatic pressure that's there, gets filtered. Over here, this is the net filtration pressure. And in general, all the forces that lead to the filtration here are called Starling forces. And here's the equation that represents it. Starling forces are those that are present for movement of fluid across a membrane. The equation seems a tad bit complicated, but let's simplify it. We can see the pi, oops, 1 second, that's my mouse. We can see the pi sign over here, and that indicates oncotic pressure. And as you can see over here, when the blood flows in by the afferent arteriole, you have the hydrostatic pressure, which is quite large, and you have the oncotic pressure in the opposite direction. Because right now, excuse me, in the Bowman space, you have absolutely nothing. So it's blank. So there are no proteins there. So it definitely does not attract any water in terms of oncotic pressure. So its oncotic pressure is 0. We can add it over here just for completeness sake, but its value is 0 when the blood is getting filtered. And that's why, as you can see over here, hydrostatic pressure is positive. It's going from the capillary into the Bowman space, whereas you have the oncotic pressure, which is in the opposite direction because the blood has all the protein at the moment. So it definitely does draw some water. But if you talk about the sum total of forces, if you add these, these three forces up, you would see that there will be a net positive pressure, and that would be pointed towards that would drive the blood through this filtration barrier into the tubules, and that's what's responsible. And once we get into the regulation, we will see how it's regulated, how the glomerular filtration rate can increase or decrease based on mainly the hydrostatic pressure. And over here, there's a net pressure of 16 millimeters of mercury, and that's why the filtration is driven in this way. Whereas after some blood is filtered, you can see that the oncotic pressure increases in this direction because now even the Bowman space will have a certain amount of protein. And yeah, basically, once pressure equalizes, there's no driving force. And that's why, yeah, you guys get it. I'm sorry. So if we talk about the regulation of flow, you have two major mechanisms. You have the myogenic mechanism and tubular-glomerular feedback. And like all other things in our body, the filtration needs to be monitored as well. And if we talk about the myogenic mechanism, increased arterial pressure stretches the blood vessels, which causes reflex contraction of smooth muscle in the blood vessel wall, and consequently increases resistance to the blood flow. Now, let's go back to, okay, you have these stretch-induced calcium channels over here. So if the blood pressure increases a lot, these stretch-induced calcium channels get activated. And if calcium is released in smooth muscle cells, they contract, right? If more calcium ions are present, they contract. So when there's high blood pressure, all these stretch-induced calcium channels get stretched, calcium is released, the muscles contract. If they contract, the arteriole constricts, and that reduces the blood flow towards the glomerulus. And that's basically what happens in this myogenic mechanism. It's instantaneous. pretty efficient. But you need to have a hormonal response as well. And that's where the tubuloglomerular feedback comes in. You have the, the juxtaglomerular apparatus that is responsible for it over here. It consists of the mesangial cells, the juxtaglomerular cells, which are modified smooth muscles of the afferent arteriole. They are difficult to see or, um, identify histologically speaking. But basically, if you talk about the afferent arteriole, they're a part of it. And if you can identify that, then those are the juxtaglomerular cells. It's all, as we saw in the earlier histological picture, all tightly organized, but all really close to each other. All of these are really close to each other. And the macula densa, the mesangial cells, the JG cells, and the macula densa. The macula densa over here is particularly important because it has a sodium chloride sensor. And the juxtaglomerular cells are the ones that secrete renin in response to the decreased renal blood pressure. If you go over a short flow chart over here, the macula densa cells, sorry, let's see water. The macula densa cells sense the decreased sodium chloride delivery to the distal convoluted tubule, which is here. They're part of it. And that leads to increased renin release because the juxtaglomerular cells are right next to it. Even though we think of, distal convoluted tubule as away from the start of the nephron, it's actually right next to it in the beginning. So they're all really close by because they're part of the juxtaglomerular apparatus. And so as renin is released, the efferent arteriole has some vasoconstriction, which leads to increased GFR. Now, let's go over it once more. You have less blood flow coming in. The blood gets filtered, and the urine is going through the nephron. Let's assume it's somewhere over here. It's going through the nephron, and it reaches the distal convoluted tubule. And the distal convoluted tubule realizes, the macula densa specifically realizes that it's not receiving normal amount of sodium chloride that it normally would. So it tells the juxtaglomerular cells that are kind of over here and over here to secrete some renin. And that renin constricts. I'm sorry, this is the afferent arteriole juxtaglomerular cells, this is the efferent. And yeah, so the renin is released and the efferent arteriole constricts, which leads to, if the blood is flowing in through like this, it's trying to exit, but it's more constricted. So there is, a kind of backflow of higher hydrostatic pressure created over here. And this entire response was because there was low blood pressure sensed, right? And it's trying to increase or keep consistent the glomerular filtration rate. It doesn't want it to drop. So if there's more hydrostatic pressure, more blood is going to get filtered. That's going to keep it close to the normal. And that's what this response is about. The efferent arteriole also responds to beta-1 sympathetic activation. That's why beta blockers can decrease the blood pressure by inhibiting the beta-1 receptors of the juxtaglomerular apparatus, thereby decreasing the renin release. This is once again another flow chart. This would be kind of another way. So if there's increased blood pressure, so there would be increased glomerular filtration rate. So increased amount of sodium and chloride is delivered to the juxtaglomerular apparatus, that's sensed by the macula densa, as we spoke about. That leads to the release of vasoactive substances from the macula densa. So vasoactive substances would increase the resistance of the afferent arteriole. Afferent arrives the first arteriole. And if that is decreased, we go back over here. If this starts to constrict, as blood is entering, it slows down. And because of that, lesser blood enters over here, or at a slower rate. And because of that, the glomerular filtration rate is decreased because at the start it was increased. Once again over here, This is for the decreased arterial pressure I spoke about. And yeah, the hydrostatic pressure, it's decreased. It's decreased GFR, decreased NaCl, thanks to macular densa, leads to the release of renin, which can, through a cycle, activates angiotensin 2, leads to increased efferent arteriolar resistance, efferent arterial, and decreased efferent arteriolar resistance, which leads to an increase in the GFR. Now, if we move on to the tubular processes, these are really, really important processes because the kidney is involved in maintaining an incredible ion balance in the entire body for, plenty of ions and substances like glucose, bicarbonate for maintaining the acid-base balance. And we know the main tubules present. Main tubules present in the nephron are the proximal convoluted tubule, the tube of Henle, the distal convoluted tubule, and the collecting duct. We have them over here, Glomerulus capsule, Glomerulus, DCT, tube of Henle, DCT, collecting duct, collecting tubule, and then into the minor calyces, major calyces, pelvis, ureter, and bladder, right? Just keep revising it, keep repeating it. That's what, let's see what the entire course of medicine is about. And yeah, let's get right into the exact details of what happens in each part of the nephron. I'll say it's quite a bit, and you definitely have to go over it a couple of times. But having it in front of you and repeating is how you get through it. Kidney physiology is really important, and you got to remember all the ion channels and what happens. But yeah, let's get right into it. All right. So once the blood is filtered, the kidney starts to reabsorb the important substances right from the proximal convoluted tubule, and as the filtrate moves on, the urine moves on, there are substances that are secreted into it as well, like drug metabolites that are toxic to the body, etc. So now the early part of the proximal convoluted tubule has a brush border. Not a brush border, it's just a histological thing that you see, but it actually indicates that it has a lot of ion channels, which you can see over here. It's a lot of activity on the apical membrane on the side of the urine, and this is the side of the blood. This is a proximal convoluted tubule. It's the early part, if we're being specific. And yeah, it reabsorbs all of glucose. That's really important. There should be no glucose in your urine. If there is, it means you're diabetic. And all the amino acids and most of bicarbonate, sodium, chloride, phosphate. I'm sorry, the font is a bit funny over here, but this is phosphate, potassium, water, and uric acid. It's really important to remember that this is an isotonic absorption. And that means that water and ions are reabsorbed in a 1:1 ratio. So if, say, 3 moles of sodium chloride are reabsorbed, an equivalent amount of water is reabsorbed. So the concentration of the urine remains consistent throughout the length of the proximal convoluted tubule. You can see here around 65 to 80% of the sodium and water is reabsorbed. I'm sorry I mentioned it twice here that it's isotonic absorption. But yeah, as I said, repetition helps. And let's go over the exact all the ion exchanger pumps. So you have your sodium and glucose co-transporter, and it reabsorbs sodium and glucose into the cell so that it can eventually reach the blood. And then you have a sodium and hydrogen antipode. These are all passive. They're all driven by the concentration gradient. And you have carbon dioxide and water, they can just diffuse through, they don't need a transporter. So that's all right for them. And then you have an antipode for any base, organic bases that you have, and chloride. I want to draw attention to this pump over here. This is one of the most entire pumps in the entire body. In the nervous system as well. The sodium potassium pump is the one that is the one that starts the nerve conduction. Without it, we wouldn't have a concentration gradient to work with for nerve conduction. But anyway, over here, it sets up a really important concentration gradient as well, and that is it keeps a low amount of sodium ions inside the cell and a high amount of potassium ions. Now, the low amount of sodium ions leads to this concentration gradient of low sodium ions over here and high sodium ions over here because blood has just been filtered in. Most of the sodium ions are over here, and we want it back. We need it back. So you have sodium that is traveling back, just following this concentration gradient. And glucose also follows this concentration gradient, and they both get transported into the cell. Again, sodium is driving now this other uh, ion channel, but the hydrogen ions get removed over here because we need to excrete them. And we need to, this part is really important because we need to reabsorb bicarbonate. So we have this breaking down over here, and then hydrogen bonds with bicarbonate to form H2CO3, which is broken down by carbonic anhydrase. Quite a quick enzyme, I might add. It acts really, really fast. And you can see that this drug over here blocks this. And, these inhibitors block it over here, just some pharmacology tie-in. And yeah, so you have carbon dioxide and water that's formed, which passively diffuse through. And again, via carbonic anhydrase, you have H2CO3 that's formed, and you get your bicarbonate back. It's really, really important for acid-base balance because if we lose a lot of bicarbonate, we'll have a lot of H plus ions in our blood that lead to an decrease in the pH that lead to acidosis. So we need our bicarbonate back. It's a very important buffer. And again, over here, sodium is the one that helps to get it back into circulation. And we have chloride over here as well because sodium and chloride are kind of buddies, and they pretty much always get reabsorbed together. Right. So let's move on to now the thin descending loop of Henle. This now passively reabsorbs water via medullary hypertonicity, and it's impermeable to sodium and chloride. So there are not really any ion channels over here. You can see over here water is getting reabsorbed. That's this is the concentrating part. The urine is getting really nice and concentrated over here. And that's because of the medullary hypertonicity. We'll come back to this in quite a bit of detail towards the end of the lecture. But basically, we have the kidney tubules, we have the interstitium, and then we have the blood vessels. So it's not illustrated over here, but you have the peritubular capillaries over here. So the interstitium is quite concentrated, and you can see over here the osmolarity of the urine is going from 300 to 600 to 900. I have a picture. Okay, this is a nicer picture. All right. You can see how throughout the PCD, the proximal convoluted tubule, the concentration of urine remains the same. Why? If you thought isotonic absorption, then you're thinking right. And as we move into the thin descending loop of Henle, the urine is getting more and more concentrated because the interstitium over here, as you can see, is quiet, has a very high osmolarity, and because of that, water is drawn out. Over here, there are no ion channels. Remember that the thin descending loop of Henle has no is impermeable to sodium chloride, so there is no reabsorption of sodium chloride happening over here. Only water is drawn out, and if water is drawn out, you're making something more concentrated. So as the urine moves down, it's getting more concentrated, and that's what happens with thin descending loop of Henle. If we move on now to the thick ascending loop of Henle, as you can see, one second, where's the mouse? Over here. Now there is reabsorption of sodium, potassium, and chloride. Right? So we have this ion channel over here. Sorry, I need some more water. All right, so you have an ion channel here that is reabsorbing sodium, potassium, and chloride. And it also, the reabsorption of the sodium, potassium, chloride, it induces a paracellular absorption. As you can see, paracellular, that's next to the cell, in between cells, of magnesium and calcium. This one ion channel over here induces the, you know, reabsorption of this because some of the potassium gets leaked back inside. We know now potassium is a higher concentration over here. So this is an active ATPase pump that is pumping potassium inside. Whereas over here as well, potassium is entering here. So there's some back leak. And because of this positive potential created here, we know now positive and positive repels. So because there's a back leak of the potassium over here, I know this sounds a bit complicated and but this is how the body works and it's pretty well set up. So yeah, just trust that and as I said, keep repeating and you'll make sense out of it. But I mean, just there is a channel that exists over here and it allows potassium to leak back. Creates a positive potential here. Positive potential tells the magnesium and calcium to exit paracellularly. And this part once again is impermeable to H2O. The thin descending loop of Henle was permeable to H2O, whereas this part is impermeable. And now, because the thin descending loop of Henle was concentrating the urine because water was leaving and there were more solutes in the urine, leaving it more concentrated. This part over here, you have the ions leaving. So the urine is starting to get less concentrated. And just if you guys are keeping track, which I'm sure you are, another 10 to 20% of the sodium is reabsorbed over here. And yeah, then the rest of these, of course, enter the blood once again. Really important over here, loop diuretics block the action of this pump over here. And because of that, you have, diuretics basically make you urinate more. And because it blocks this pump, there's a more in-depth mechanism to how it leads to diuresis, but it's just this pump which you want to remember. Sorry, not this pump, this ion channel that the loop diuretics block. If we move on now to the early distal convoluted tubule, again, there is another 5 to 10% of sodium and chloride reabsorbed. It's once again impermeable to water. Don't worry, the collecting tubules are permeable to water, but we'll come to that in the second part of the nephrology lecture. And this makes the urine fully dilute and hypotonic because there's a further amount of ions that are reabsorbed and water is leaving. So if only ions are leaving, then the urine is naturally becoming hypotonic. You have some more magnesium and calcium that's reabsorbed over here. You want to keep track of this channel over here. The reason why sodium is reabsorbed so much is once again because of this ATPase pump creating a low concentration over here, which consistently creates a high concentration here and helps to reabsorb the sodium that's there. And yeah. Now, if we move on to the examination of renal function, especially clearance, the glomerular filtration rate is the best way to measure renal function, and it can be measured by calculating the clearance of a marker. Now, we have some qualities that we want to keep in mind for a marker. It must be freely filtered across the glomerular capillaries with no size or charge restrictions. It can't be reabsorbed or secreted by the renal tubule, and when it's infused, it shouldn't alter the GFR. We'll keep this in mind and we'll explain it with an example. So, there's this one substance called inulin, and it's really it's a winner. Okay, it it ticks all the boxes for an ideal renal marker. It's freely filtered, it's not reabsorbed or secreted, and it does not to the GFR. So it's really great. You can inject uh, a predetermined amount of inulin. So you are aware of the plasma concentration of inulin, and then as the patient urinates, you measure the amount of urine concentration of inulin in the urine, and then you measure how fast it's exiting, how fast the patient is urinating, how often. Usually they have a catheter attached in these situations, and yeah, with with this measurement you can find out the renal clearance, you can find the glomerular filtration rate, and if you find the second is not sorry. So this is a formula for the clearance of inulin, and it just so happens that the clearance of inulin is equal to the glomerular filtration rate. Now, it is the perfect marker, as I mentioned, but what is the downside? It doesn't occur in the body naturally. So we need to apply it via IV, which you would think is alright, but in medicine, generally, what we try to do is try and be as less invasive as possible for the patient. So, who do we look at? Creatinine. Um, Creatinine is a substance that is naturally present in our blood because it's a product of like a breakdown of muscles, and it's got to take into account the body weight and the gender and those sort of things. So the formula looks a bit more in the age. The formula looks a bit more complicated, and but the thing is, we don't mind it because you know it's not invasive. It's naturally occurring. It can be much easily measured. The only issue with creatinine gets secreted a little bit by the distal convoluted tubule. So that makes it overestimate the glomerular filtration rate. Say you have X amount of creatinine in the blood that gets filtered, it's going via the tubules, it's going via the tubules, thin descending loop of Henle, thick ascending loop of Henle, it reaches the distal convoluted tubule, and then you have a certain amount of creatinine. It's also secreted over here. So you have X plus a small amount of Y. And because of that, the glomerular filtration rate gets slightly overestimated. But again, because of this formula and that is adjusted accordingly, then we get quite an accurate measurement, and it's much easier because the patient does not have to be disturbed and injected with inulin. And you can see over here why glomerular filtration rate can be used as, uh, can be used to assess renal function. You can see over here as the plasma creatinine is very high, it should be in an acceptable range, but when it's not, the glomerular filtration rate is really, really less. And that's why creatinine can be used as a marker for finding the glomerular filtration rate. And this is why glomerular filtration rate. So when you have kidney failure, the glomerular filtration rate decreases quite a bit. And when you measure the creatinine, the plasma creatinine concentration in a patient with acute kidney failure, you find very high concentrations of it, of blood urea, nitrogen, and creatinine. So these are the sort of things, these are the reasons why it's really important. Here are some additional formulae that you can take a look at. I'm not going to go into explaining them a lot because they can be sometimes situation specific. Glomerular filtration rate and clearance are the most commonly used formulae. But in some parts of pathology and pathophysiology, you will have these mentioned as well. So I've mentioned them over here. Fractional excretion of the sodium, which is just the amount that's excreted by the amount that's filtered role, the excretion rate, etc., etc. Relatively simple stuff. Whatever the terms are quite simple, and the definition is basically if you just repeat the term is the definition. quite straightforward stuff. Anyway, so moving on to quite an interesting part of renal physiology, which which is a little bit complicated, but I think once you understand it, it's quite fun to go over. It took me quite some time to understand it, but I hope you guys get it with this explanation. Please let me know if you have any doubts I forgot to mention during the lecture. Please comment down below at any point if you have any doubts. So, water reabsorption is taking place throughout the length of throughout most of the nephron. We saw that. One second for the mouse. All right. So that is filtered by the glomerulus. We saw there's isotonic absorption going on over here. Water was getting reabsorbed over here. And as it moved down, then descending into Henle, quite a bit of water reabsorbed. That's what made the urine concentrated. This part was impermeable to water, so was this part. And then over here, you have some more water getting reabsorbed in the collecting tubule and so on. So one concept over here that's really, really important for that helps in reabsorbing water is the countercurrent multiplication. And it's basically the fact that the kidney uses energy to generate an osmotic gradient that allows you to reabsorb the water. There are two major mechanisms and concentrators of the interstitium, and that is sodium chloride and urea. So remember we had spoken about the sodium, potassium, and 2-chloride ion channel in the ascending loop of Henle, which the loop diuretics block. So that ion channel makes sodium and chloride go into the interstitium, and it's quite an important ion channel because it increases the concentration of the interstitium. You can see over here how the osmolarity over here is quite high of the interstitium, and this channel definitely does contribute towards it. Also, in the collecting duct, urea in the medullary part, in the medullary part of the collecting duct, it is permeable to urea, and throughout the length of the nephron, urea is not allowed to leave the tubule, the renal tubule, because we want to excrete it. We want to get it out of our body. We don't want a lot of urea inside our body as it can get toxic. But this part is permeable to urea, and since it's so concentrated over here, it's allowed to leave. But it enters the interstitium of the blood. And because it enters the interstitium gets really, really concentrated. So in general, you can see how the concentration of the interstitium is quite high. It has a high osmolarity, and that's what draws the water out. The fact that this part is permeable to water, it draws it out, and this gets concentrated. And well, over here we know that sodium chloride is reabsorbed. That's why the concentration starts to decrease again. But you can see how it equalizes. The concentration of the urine is 1000 milliosmoles per liter. The concentration of the interstitium is also the same. And it equalizes. It's continuously equalizing because water is continuously leaving. And that's what this countercurrent multiplication system does. It allows us to reabsorb the water and get it back when we are dehydrated as well. The antidiuretic hormone acts on this pump over here and increases the amount of sodium and chloride reabsorbed. So the interstitium is more concentrated, so more water is reabsorbed. So we get more water back when we are thirsty. Desert rodents. So over here you can see 1200 milliosmoles. Desert rodents have such a long loop of Henle, such a long medulla, because they got to save even more water, obviously, and their osmolarity of the interstitium can reach up to 3000 milliosmoles per liter. Just imagine, it's more than double of ours, and that's because they really need to reabsorb quite a bit of water because when the desert. And yeah, So that pretty much covers water reabsorption, the countercurrent multiplication. Another thing I want to mention earlier for renal clearance, the GFR of a normal adult male is around 100 milliliters per minute. Just remember, keep the value in mind. This is kind of what this is the goals. This is the ideal amount, the glomerular filtration rate that we would like, showing good renal function. And yeah, please let me know if you have any doubts, especially about the countercurrent multiplication. It's quite an important concept, but I hope I've made it slightly simpler. You have two major concentrators, as mentioned over here, NaCl and urea, and it draws water out, and that's its main point, and it also concentrates the urine. But the main point of the countercurrent multiplication is to be able to reabsorb the water. And that brings me to the end of the lecture. Please, yeah, do fill out the feedback form and know how you think of this, and if there's anything you feel like needs to be added or should be covered in more detail or slightly better, I would really appreciate the feedback, and hope you all have a great day, stay safe, and yeah, take care. Thank you.